Next talk be by Dr. Ajoy Tiwari. He is a known cardiologist and academic in the field of the diabetes and cardiology. I invite Dr. Ajoy Tiwari for their talk on the systemic analysis and the waist height ratio versus body mass index to predict the cardiovascular complication in people with diabetes. It is a very important topic, and that will be covered by Dr. Ajoy Tiwari.
Thank you, Dr. Ashutosh Mishra, for giving me this opportunity to discuss a very pertinent topic, and this is waist height ratio versus body mass index. So this is one of the anthropometric measurements, and this has been with us for a very long time, but in last few years, after a large number of systematic analysis, this has started gaining ground. And now in next 10 to 15 minutes, I will be walking you through why it is important, how it compares with the other parameters, the body mass index, waist hip ratio, and waist circumference, and how it outperforms those things, and why it is pertinent in our setting, that is the Indian setting. So coming to the basics of obesity. So obesity is defined as an excessive accumulation of fat in the body resulting in adverse effects on health of the individual. The pathogenesis of obesity involves the interaction of genetic, environmental, and behavioral factors, and excess body fat increases the risk of death and major comorbidities. So we all know about this. So the traditional approach has been to look for the body mass index, but we have other anthropometric measurements because we had some issues with the body mass index because it was not giving us the location of the fat where it is important, and over a period of time we have understood that which particular part of the body is having the fat, that is also of great importance. So waist circumference, waist hip ratio, waist height ratio, they have all started gaining ground. So this is how we do body mass index. So traditionally we use it, and it is accepted all across the world as an important parameter. But the body mass index, we have got different values for different ethnicities. So that is a very important thing to understand. So it is not one parameter which encompasses the entire world population. So the same holds true for the waist circumference also. We have ethnic variations in the waist circumference, and we have different values for different populations. And the body mass index, where it fails because it has a very good coverage of normal BMI, overweight and obese, but it does not encompass into the other factors, that is the normal weight central obesity and the metabolically healthy obesity. So these things are not included in it, and we all are well versed with this particular slide that for the same BMI, our Asians, Southeast Asians have more abdominal obesity. So coming to the point, why BMI is not enough. So it may not show the relative adipose tissue and the lean body mass measurement. So that is the most important thing, and the central adiposity is now being increasingly recognized as the forefront for the cardiometabolic conundrum. So we need to move beyond BMI for the right assessment of obesity. So what else we have? Waist circumference, waist hip ratio, and the waist height ratio. So although BMI, waist circumference, and WSTR are by their very nature strongly correlated, the most important question is to ask which anthropometric proxy measure is the simplest and most accurate in helping to indicate the early health risk. So over the next few slides, I will be walking you through this. So WSTR versus waist hip ratio. So the waist hip ratio is not helpful in practical risk management because both waist and hip can decrease with weight reduction. So both the parameters, be it the waist as well as the hip, both will decrease when the weight will decrease. So sequentially you cannot have those things. And the WC is a height dependent variable. So this is to be understood because taller children generally have larger waist circumference than the smaller children. However, the height is not, if the height is not taken into account, when obesity is defined based on age dependent waist, this WC percentiles, the degree of central adiposity can be overestimated in tall children. So a taller child will have a bigger torso. So you will have a bigger waist circumference. But that is not so, and we have to include height into these measurements to get the right assessment of the cardiovascular risk. So, how do we WSTR versus waist circumference? So, measuring waist circumference without height adjustment may lead to overestimating fat mass in tall subjects and underestimating in the short individuals. So, and this waist circumference, the other issue is that it requires specific values for various ethnicities. So, it is not the same. It is for Southeast Asians we have different values, 80 and 90. For Caucasians we have different values. So, why WSTR? WSTR is the ratio of waist circumference and the individual's height. It is easy to report, not being affected by usual factors such as age, sex, ethnicity, and it negates the use of scales. So, that is very important because all these factors are negated when we are going for WSTR, and the recording is also very simple. More than 0.5 and less than 0.5. That is simply that your waist circumference should be less than half of your height. So, it is very simple to communicate this message to our people. So, adult height remains largely constant. So, if you undertake this particular measurement once, you understand the with the waist circumference this value will increase or decrease, but because the height is constant, this value will remain otherwise constant. The height factor will only be included only once. So, do we have any validation? Because this is a anthropometric proxy. So, how does it compare with the actual markers of these things? So, these are the studies. The WSTR showed better results than waist circumference and BMI for predicting percentage body fat measured by dual energy X-ray absorption. So, DEXA scans, we have a comparative study. Then there is a systematic review comparing measures of body fat in 7 to 10 years old children, reported that BMI and waist circumference was strongly correlated with the body fat as measured by the bioelectrical impedance or skin folds, whereas the WSTR showed a moderate positive correlation between body fat estimated by the air displacement plethysmography. And I would tell you that air displacement plethysmography or underwater weighing, they are the most standard measures of measuring the body fat. So, this is how it scores to that. So, the waist height ratio can be used without the aid of scale or reference to BMI categories. Simple cutoff 0.5, and it is same regarding the sex and ethnic origin. Patients can be told your waist should not exceed half of your height. So, measuring, that is the simple, we have to go for the waist circumference, that is from the, we have to place the tape midpoint between the last palpable rib and the top of the eye leg crest, and the height we can measure with the stadiometer. So, it is cost effective because the measuring of BMI requires weighing scales as well as the stadiometer for measuring height, and the WSTR requires a tape measure and stadiometer. And even there are studies in Thailand which have shown that even you do not need a stadiometer for this, even a simple NADA could be helpful in measuring the height and weight. So, this could be very practical in the primary care settings. So, now coming to a few limitations also. The limitations are that does not account the fat distribution between different ethnic groups, age groups and sexes. So, WSTR does not distinguish between subcutaneous and visceral fat. So, that could be a problem, but we have to understand that this is a primary anthropometric proxy. We are not going to go for this is more of subjective, it is not more of objective. So, we have to understand that what we are trying to see and in what context we are talking about WSTR. So, it does not consider the muscle mass, bone density and bone frame of the individual. So, we are not going for specifics, we only want to assess the cardiovascular risk of the individual. So, may not be applicable with extreme heights such as very short and very tall people. So, these are all the constraints with WSTR. So, again these are the studies. The cardiometabolic risk may differ between people with the same waist circumference but different heights. It was reported that taller populations have lower mortality from ischemic heart disease and stroke. So, there are large number of studies with us which have shown that taller people have lesser instance of cardiovascular disease as compared to the shorter people. So there are long studies, and the people were followed over years altogether. The study from Wales, from United States, which they have shown that this is very pertinent. And the Schneider et al., this group has showed that the shorter subjects were at a higher risk and at a 30% higher prevalence of metabolic syndrome than tall subjects when grouped by waist circumference and not by WSTR. Then a new concept is emerging, and now they say that if you include waist circumference and body mass index, what we call as the matrix of waist circumference and BMI, so how then we can include this thing. So now there is another study by Margaret Ashwell. So they compared this matrix of waist circumference and BMI with WSTR. So they found that when we used even these two parameters, that is the waist circumference with BMI, still we were losing 35% of the patients who were at the increased risk of cardiovascular risk. So still 35% of the patients had a WSTR of more than 0.5%, and they were at greater risk. So the cardiometabolic risk factors in the healthy BMI group made it clear that the people who have a BMI in the healthy range but have WSTR of more than 0.5 had higher risk factor levels that were less favorable than those in the healthy BMI range with WSTR less than 0.5. So those patients who were labeled as low risk with this matrix of BMI and WC, still there were 35% of the patients who had an increased risk. So there are n number of studies and systematic reviews. Few of them I am elucidating over here. So they have compared WSTR with BMI, and they have found that it is a better predictor of coronary artery disease. Then we have studies which have shown that WSTR outperform BMI in predicting metabolic syndrome and diabetes, cardiovascular risk, and cardiovascular and all-cause mortality. Another systematic review in elderly population showing that WSTR outperforms BMI as regards to the prediction of diabetes, metabolic syndrome, and the cardiovascular risk. This is another study of 88,000 patients in Asian countries by Lee et al., and they found that the WSTR was a better discriminator for hypertension, diabetes, and dyslipidemia in both sexes. Another meta-analysis including more than 30,000 adults, that WSTR was superior compared to BMI and waist circumference in identifying adults with cardiometabolic risk. This is also very important. Another Korean study, and they showed that that WSTR performs better than BMI in predicting the presence of metabolic syndrome. The Kim et al. Study, they showed that it is using the 10-year Framingham coronary artery disk risk score, 20% more chances of a better prediction with WSTR as compared to the BMI. So n number of studies, and the literature is full of them. And this is from the Advance On trial, that was a randomized controlled trial, and where they compared WSTR with BMI, and the WSTR marginally outperformed BMI as a reduction, as a predictor for the cardiometabolic risk. So this was our systematic study from which we have derived most of these factors, and this was a published study, and this is with Professor Anuj Maheshwari, who is in the audience, and this is the summary of the evidence. What we generated was that the WSTR is probably a better diagnostic predictor than BMI or waist circumference, and we have found that 0.6 is a better predictor for increased cardiovascular risk in people with diabetes, because this particular systematic analysis was done in the people with diabetes. So how does it find now its place in various guidelines? So the NICE 2022 guidelines, they have said that they have proposed that all adults ensure their waist size is less than half their height in order to help stave off serious health problems. So this is part of the national guidelines also, and the most recent ATA standards of care, they have also incorporated WSTR as one of the anthropometric measurements. So the use of WSTR addresses a current dilemma of how to best identify early health risk with a very simple, low-cost anthropometric measure. The predictive value of WSTR is backed by systematic reviews and meta-analysis in many different populations. So I will end by this very poignant observation by Poirier et al. And what they said that the clinician should look beyond BMI. Although assessing for total fat mass with BMI to identify patients at greater cardiovascular risk is a good start, it is not sufficient. So a simple message for our teeming masses, your waist should not exceed half of your height. So thank you for patient hearing, and I am open to questions.
Nice talk by Dr. Ajay Tiwari on the height and waist ratio, which is important for covering all the metabolic complications and its management. And it is a good message for all our clinician. The height and waist ratio should be half. Any questions from the audience? They can interact with Dr. Tiwari.
Yeah, so I had already showed you with some of the limitations of this particular parameter. But if so, in the extremes of ages, so that is one way where we have to be careful. We have to be careful about this thing. But in most of the circumstances, because what we are looking for an early proxy to predict cardiovascular risk. So in that way, it outperforms.
Hello? It's it is a